Hello, I'm Dr. Bruce Troen. I'm co-director of the Center of Excellence for Alzheimer's Disease, and I'm also the chief of the Division of Geriatrics and Palliative Medicine. And I'm going to present a short talk on the pharmacologic and non-pharmacologic management of behavioral and psychosocial disorders in dementia. I have no disclosures for this presentation. So in general, it's very important to know what the physician role for dementia patients should be. Certainly, we want everyone to make a thorough evaluation so that we can make the diagnosis. And we want there to be honest information. We want to provide the truth to the patient and the family and caregivers, but do it in a manner that is not a bludgeon. And of course, there needs to be continuing care. And when we talk about the patient, almost always we're thinking about the family and the caregiver, as well as the patient who is really the victim of plaques and tangles for Alzheimer's disease and other changes in other non-Alzheimer's disease dementias. So it's important that we really test the waters, have reality testing. We need to know when it's appropriate and when the right time is to provide specific support services, and then perhaps ultimately institutionalization if needed. And there are often ethical choices that we need to make for end-of-life care as the patient progresses in the disease. And this may not be something you do at first encounter, but you should not wait for a crisis either. So of course we want to maximize general medical health. We want to decrease the excess morbidity that can come by with other chronic illnesses, because all of those could have the potential to worsen cognition. So therefore that means we still need to have good periodic examinations, appropriate lab screening based on the necessary problem list, and we have to still provide interventions and screening that makes sense. Vaccines, mammograms, maybe endoscopy in the GI tract. But presumably all of these should take place only if they're consistent with the goals of care and advanced directives. And of course, if there's a sudden decline or a change in the status of the patient, you need to have a comprehensive evaluation. Delirium, unfortunately, is very common in dementia patients. And we need to remember that dementias, such as Alzheimer's disease and vascular dementias, don't worsen overnight, though the latter may do so if there is a sudden cerebrovascular event. So, an area that is sometimes very vexing to deal with is when there are behavioral and psychological symptoms that are associated with dementia. And indeed, the International Psychogeriatric Association about 20 years ago defined this as being a heterogeneous range of psychological reactions, psychiatric symptoms, and burdensome behaviors that occur in people with dementia of any cause. So there are a number of types of biopsychosocial disturbances in dementia. The affective disturbances, which are most common, can be looked into the following categories. That would be depression, apathy, anxiety, and irritability, and frankly, oftentimes a combination or mixture of these. The next group are those psychotic disturbances, which often can create a very disturbing persona for the patient and the family, and could involve delusions or hallucinations. Then there could be neuropsychiatric disturbances, and this really is the category that involves agitation, and we'll talk about that later, about how to approach that. And then motor disturbances, which are really not just motor, but brain-body disturbances in the sense that patients could end up wandering or even pacing in a repetitive manner. So in order to assess these changes, it's important to follow a good routine, which means taking a thorough history of the patient, looking at the primary presenting symptom, and oftentimes you need to get this, of course, not just from the patient, but from the patient's family or caregiver. And you need to think about associated symptoms. And very, very importantly, you might find that rather than there being a specific symptom that you might associate with a disease or an organ system, that you should look at functional capacity of the individual. And that means understanding the impacts on activities of daily living and the instrumental activities of daily living. Now, the IADLs may already have been significantly affected by the pre-existing dementia, but when we come to the activities of daily living, changes in behavior, inability to put on your clothes, inability to successfully conduct hygiene or toileting, or even to be able to eat your food, those could be tip-offs to changes. So, of course, you need a medical history that includes understanding what comorbidities are not only present, but might also be supervening. Absolutely essential is to know what medications, both prescribed and over-the-counter medications, are being given. Social history, which is, of course, relevant in many circumstances in the geriatric population, but important to understand what may be triggering factors within the home environment and with family members. And of course, to understand whether or not the patient, even if there's a setting of cognitive impairment, might be engaged in excessive alcohol or illicit drug use. And of course, the psychiatric history. Moving on a physical examination, in addition to the typical regular physical examination, you need to do a neurologic assessment and a cognitive assessment. Now, if you've already got a baseline mini-mental status examination or Montreal cognitive assessment, it'll be very important to get a new one so you can see if there's a trend, if there's a decline. In this sense, it's also important to understand whether or not the patient has a delirium. And for this, really, the confusion assessment method is really very helpful and very straightforward to use. And that's something that can be found, for example, in the writings of Dr. Sharon Inouye, who helped develop it, and also on the Hospital Elder Life Program website. And of course, you want to look at it if there are any sensory or motor deficits, particularly as these may reveal a cerebral vascular event, which in the setting of vascular dementia could result in a sudden change. Laboratory tests, well, in addition to the routine CBC or chemistries, you want to know about thyroid function tests. You also want to know about liver function tests, and perhaps very importantly, and hopefully having done this previously, get a B12 screening and perhaps a VDRL. Though the bad news there is that while we of course want to treat tertiary syphilis, once there are psychiatric symptoms, it's unlikely you're going to get a reversal by treatment. Standardized neurocognitive assessments could be very important. So going beyond the typical screening instruments in the office setting, which might include not only the MMSE and the MoCA, but also the AD8 or the MiniCog, that it may be very worthwhile, even at different stages of the illness, of the progression of dementia, to have neuropsychometric batteries. And they're often a restricted set that can be utilized, though this is best done with a neuropsychologist. And what about neuroimaging? Well, if there is the suspicion that there's been a stroke, then neuroimaging may help to confirm that. But there are almost no other circumstances that you would really get neuroimaging, because it's really the goal to rule out an acute process. Perhaps the one exception would be if there's a fall and you're worried about a subdural hematoma. So what are some of the guidelines for treatment? Well, of course, when it comes to dementia and its associated phenomena, it's important to give it a name. So we should not shy away from saying dementia to family members. There may be a lot of questions about whether or not it's Alzheimer's as opposed to vascular or Lewy body or frontal dementia, but I think the key is getting the family and the patient, if he or she is able to understand that the word dementia is not a stigma, but is an important descriptive element. Of course, you need to partner with the patient and the caregiver. Absolutely essential. It takes a team. It not only takes a team with the family members, but it takes a team with other health professionals that includes social worker, occupational physical therapist, pharmacist, nurse practitioners, and regular nursing and home health aide. Then, what are the general treatment strategies? And I want to divide them into two categories, non-pharmacologic and pharmacologic. So when it comes to pharmacologic management, it cannot be stressed enough that, as this quote from the paper just a few years ago, that when viewed together, non-pharmacologic interventions demonstrate a statistically significant improvement in biopsychosocial disturbances in the setting of dementia. So the first three things you should be thinking about are what kind of supportive non-pharmacologic interventions you can undertake. These often include and need to include education of caregivers at every step along the way so that they understand the disease just as much as possible, and they understand the potential harms that might be associated with resorting to pharmacologic intervention. And it's very important in a preventive and also in a responsive mode to stress that there are things you can do in the home environment to help support the patient. That means having scheduled toileting, for example, having behavior modifications, and this is very important where family members and caregivers can undertake strategies that avoid escalation, and perhaps can de-escalate situations. And by the way, often caregiver support groups are the places where family members can really learn these techniques and, of course, get the support from other people undergoing this same kind of situation. Exercise is important, and while this is still an area of evolving investigation, we believe that if it can be done, it can be very helpful. There are different reports, both anecdotal and some evidence report, on the benefits of music therapy, massage therapy, and even pet therapy. And it's also important to remember that environmental modification is important. And that means that the patient should have a safe space to wander if he or she needs to. And also, we need to remove anything that potentially is unsafe, toxins, weapons, and also perhaps even preventing access to areas that might provide hazardous environments like the kitchen. So what are the potential caregiver interventions? Well, if appropriate, the use of respite and adult daycare can be very helpful. After all, we want to avoid caregiver burnout just as much as treating the patient directly. You want to simplify and structure the home environment. You want to avoid having the patient drive if possible and create a home-safe environment. And then, as we alluded to earlier, we want to have goals of care discussions so that advanced directives and perhaps even long-term care and financial planning are undertaken. So it's very important to think about the caregiver's physical and mental health. Think about how the primary care visits could coincide with the Alzheimer's disease patient so that family is involved. Caregiver burnout is a huge problem, and there's a big financial burden on our society with that. You need to know who the contact person is, have all appropriate information, and of course, if available, and in Western New York, it certainly is available with the Alzheimer's Disease Association, find community organizations that can help. So what kind of drugs, if necessary, if absolutely necessary, can be used for dementia behavior disorders? Well, antipsychotics have occasionally demonstrated good results in randomized trial, but it should be noted that these are off-label uses. It's very important to be sure that symptoms, when occurring, justify the use of what are effectively dangerous drugs. So agitation, aggression, or delusions that disrupt care and impair life quality for caregiver and patient would be the justification. There is data about these atypical antipsychotics that have made it into our armamentarium, but they're often conflicting. They may be easier to use with fewer daily side effects and perhaps sedation or movement disorders, but there is an FDA black box warning for stroke or even cardiovascular and sudden death. These may also occur with typical agents, but they're not as well studied and documented. So what about pharmacologic management? Well, there are the disease-modifying agents such as cholinesterase inhibitors and NMDA receptor antagonists. I don't want to focus on those right now because what we want to see is what you can bring to the table when there are changes in the behavior of an existing dementia patient. So the question is, can you resort to agents such as antidepressants, whether they be SSRIs or SNRIs? And the answer is yes, but again, done very, very cautiously. If there's a sleep disturbance, then low doses of trazodone may be very beneficial. And when it comes to depression per se, and if there's any decrease in appetite, mirtazapine may be effective. Very important to say to avoid tricyclic antidepressants because of the anticholinergic effects. And at present, there's not a lot of data to support the use of bupropion. There is some evidence to suggest that mood stabilizers may help, such as valproate, carbamazepine, or gabapentin. But these, again, need to be used in the context where side effects are carefully paid attention to and where we often remember the geriatric dictum, start low and go slow. And I like to add to that sometimes less is more. So when we think about antipsychotics, there are both the typical first-generation antipsychotics, such as Haldol, chlorpromazine, and fluphenazine, and then the atypicals, the second-generation, risperidol, quetiapine, clozapine. Again, I want to stress that using these agents should only be done in the setting where there is potential disruptive behaviors such as agitation that could actually lead to harm of the patient or folks around them. There are risks for atypical antipsychotics, to which I alluded to just a few moments ago. The FDA had a review of 15 placebo-controlled trials, and unfortunately, of the 17 controlled trials, 15 of them showed increase in risk of death with these antipsychotic agents, the atypical ones. There's increase in heart failure, sudden death, and pneumonia, And this may even be true for some of the more recent atypical antipsychotics, such as ziprasidone and clozapine, but data is really not that prevalent. So it's very important to take this into account, to use great caution, and to realize that the information is still very incomplete when it comes to using these agents. There are some medications that you absolutely want to avoid. Those that have pronounced anticholinergic effects. A good place to find indications of that would be to look at the Magellan Anticholinergic Risk Scale, which grades a large number of medications to their anticholinergic side effects. These can cause delirium and a number of other side effects, which can be very disruptive, especially in patients with pre-existing dementia. We want to avoid benzodiazepines because of their sedative effects. As a matter of fact, in general, sedatives and hypnotics are to be avoided, with the exception of something like trazodone, which may help in the setting of sleep disturbance. So there's some general principles of dementia care which I'd like to reemphasize again. Sometimes, because of the inability of the patient to report carefully what the signs and symptoms are, complicating diseases could be missed. You need to remember that hospitals could be dangerous places, so with good preventive care, you want to avoid hospitalization if possible. A patient with dementia has a brain that is very sensitive to drugs, and you want to avoid them if possible. You also want to give appropriate therapy and not be biased against the patient because of his or her age or dementia. Treatments should be very carefully considered, and symptomatic treatment without evaluation is dangerous. So please, you need to see the patient, evaluate carefully and comprehensively. And you need to stop any treatments, any medications, in where you believe there might be side effects, and the side effects can often be worse than the symptoms. So we know dementia is common, but it's never normal aging. Alzheimer's dementia is the most common, and it's often followed in order by vascular dementia or dementia with Lewy bodies. We need to have a thorough evaluation, both for the diagnosis of the dementing illness and the identification of comorbidities. We need to direct treatment at function and quality of life, and we want to use behavioral interventions and only then consider drug, and then think about how social and other resources can supplement care for the patient and family members. And here's the take-home message slide. So early assessment and diagnosis of the biopsychosocial behaviors is critical because we want to first do no harm. There has to be a team approach. You're partnering with a patient and caregiver, and you can use non-MD members of the team to good effect. We need to identify and manage the disturbance and be able to understand if it's affective, psychotic, neuropsychiatric, or motor. And then again, I cannot say this too often, that non-pharmacologic management is the first-line therapy. But in addition to that, if absolutely necessary, think about how we can use drugs, which even though there are no FDA-approved drugs, to deal with the additional effects, and to remember good principles that you have to start with low doses, you have to continuously evaluate the response with the help of caregivers, and you have to titrate slowly, and remember that you can taper and discontinue these when the patient is clinically stable. Thank you very much for your attention.